Hello, hello. Can everybody hear me?
Yes.
Yes.
Yes. Okay.
The Edo Professionals in Diaspora is coming back with their fourth show on Apple TV this weekend. Date 20th February 2021 at 7 p.m. Nigerian time and 1 p.m. Canadian time to present Head and Neck Cancer. The program is featuring a Canadian healthcare professional, Dr. Stephanie Obaseki. The show will highlight the prevalence area of head and neck cancer in Nigeria, the risk factors of head and neck cancer, the signs and symptoms, the diagnosis, and treatment. Furthermore, Dr. Obaseki has additional consultation service for Edo State. Join us this weekend on Nebo TV.
Hello, everyone. Hello. Can everyone hear me?
Yes.
Yes.
Okay. So my name is Nekme Obasogie. We are back again with our fourth show on Edo Professionals in Diaspora. Today we're going to be presenting head and neck cancer. Before we start the program today, I would like to introduce the healthcare professionals in the studio. We have 4 healthcare professionals today. The first person is Dr. Dorothy Ayala. Thank you for joining the program today.
Thank you for having me.
Next, Dr. Aima Musa Eroje. Thanks for joining the program today.
Thank you for having me.
Okay, a Canadian healthcare professional, Dr. Stephanie Obaseki. She's here today to present head and neck cancer. You are welcome to the program today.
Thank you for having me.
And our healthcare professional, Dr. Nusakari Obano.
Thank you very much for having us.
Okay, sir. So before we start the program, I would like Dr. Stephanie to introduce herself a little bit to the audience. Go ahead.
Thank you. I'm just going to make my screen a full screen now. So as mentioned, I'm going to be reviewing today some of the most common head and neck cancers. My name is Stephanie Johnson Obaseki. So thank you to everyone for spending their Saturday with us, and thank you for the invitation to speak to you. I'm an assistant professor in head and neck cancer, ablative and microvascular reconstructive surgeon at the University of Ottawa and the Ottawa Hospital, and I also have an affiliation with the Ottawa Hospital Research Institute.
Okay. So quickly, one question. Have you been practicing with African people? Have you visited Africa before?
Yes. So I have spent time working in some African countries, including Uganda. And it's not an African country, but I've also spent some time working in Fiji as well.
Okay. Thank you. Thanks for joining the program today. Dr. Aima from the United Kingdom. Go ahead. Introduce yourself a little bit to us. I know that you are a dentist.
Yeah, hi there. And thank you for having me, and thanks to everyone for tuning in. My name's Dr. Aima Musa Eroje. I'm a dentist and I'm based in the United Kingdom. I'm excited to be here. Got a really good lineup of speakers. And yeah, thank you for having me. And I look forward to hopefully helping you out and informing you as well.
Thank you for joining the program today, our young doctor. Thanks. So we have Dr. Dorothy Ayala. Go ahead and introduce yourself a little bit to the audience, ma.
Oh, thank you. I'm Dorothy Ayala. I'm a nurse practitioner, and I practice in Toronto, Canada. And also, I'm a professor of nursing and also a program coordinator at the nursing program.
Thanks for joining the program.
Thank you.
So we're going to start today's program with Dr. Stephanie Obaseki. She's going to be presenting head and neck cancer. It is my first time of hearing about head and neck cancer. I hope many people who are watching right now will enjoy today's program and learn from it. So I'm going to pull out the presentation right now. Okay, go ahead.
Okay, So I'll just dive in. So some of you might wonder how I became an Obaseki. So I'll quickly tell you that story. I'm actually originally from Winnipeg, Manitoba, which for those of you that don't know is right smack in the middle of Canada. And it's, well, at the time that I created the presentation, it was minus 37 degrees out. And so if anyone's wondering why I left, I think that's probably fairly self-explanatory. So after high school, I moved to Ottawa and I did my undergraduate degree and medical degree, as well as my residency training in Ottawa. And then I moved to Toronto to do my subspecialty training in head and neck surgical oncology and microvascular surgery. And then I went back to Ottawa to start my practice. So that's me in the OR. And you might be wondering why I'm speaking to you today. So this fine gentleman is my husband, Ihenedin Obaseki, and he and I married and have these 3 children. And so that's my connection to you and why I think I'm here to speak to you today.
Thank you. Thanks.
So the objectives for the talk today are to review the most common types of head and neck cancers in Nigeria. These include oral cavity cancer, oropharynx cancer, nasopharynx, paranasal sinus, and larynx. And my goal is to review relevant information on epidemiology, etiology, treatment options, and then survival outcomes. So what is head and neck surgical oncology? I'm a surgical oncologist. And so that's the treatment of all different types of cancers, the ones that I had just highlighted that we'll be reviewing today, but it's also a number of other cancers, cutaneous cancers, which are common in the Western world, glandular cancers such as thyroid and salivary gland, and then mesenchymal cancers like sarcomas. And this over here is a cross-section through the mucosal surfaces that I'll be talking about today. I hope you can see my little arrow, can you?
No, you should share it yourself, like yesterday.
Yeah. That's a slide. Yeah.
Press the slide.
Next slide.
Okay. Anyways, so this shows the mucosal surfaces. At the top is the nasopharynx, and then the oral cavity and oropharynx, and then just down below there you can see the opening of the larynx.
Yeah, we are not seeing your slides.
You're not seeing my slide?
Share.
Oh,
Yeah.
okay. There you go.
Can you let her share the way she did yesterday? It's better.
No, she has control over the presentation.
Oh, I'm sorry about that.
Okay.
I was sharing. 1 second. I'll do that again. Okay, sorry about that.
If you can expand it to full screen. Oh, okay. Reshare it again. Reshare it.
Okay, share. There. Are you able to see it? Are you able to see it now?
Yeah, you can say go ahead.
And do you see my little arrow as well?
No, the arrow. Can you bring the arrow to the middle? The middle of
There.
the slide. Oh, okay. Yes, we can see it now. Go ahead.
Perfect. Okay, great. Thanks. So the head and neck is kind of an interesting area to practice because of its proximity to very important structures like the eyes, the intracranial contents such as the brain, the thorax, and the spine. And so overall, head and neck cancers constitute about 5 to 8% of all total body cancers in Europe and America. It's a bit difficult to relate this to quantify the numbers in Nigeria because most studies are small, retrospective, and hospital-based, and there's no community-based or population-based databases. Having said that, I did find some studies that helped to quantify the numbers of cancers in different areas in Nigeria. So it does seem as though there's a different number of cancers in the northern part of Nigeria, and that's a bit different than what you see in the middle and the southern part. So in the northern part of Nigeria, you see most commonly what's called nasopharynx and cancers of the paranasal sinuses. And head and neck cancers are quite common. These two are quite common in these areas, up to 20% of all cancers. And then you can contrast this with the middle portion, sort of like Abuja southwards. And in that situation, in those areas, oral cavity cancer and oropharynx cancer are more common, followed by nasopharynx cancer, larynx, and paranasal sinuses. So I mentioned that there aren't that many population-based studies, but I did find these two that were quite helpful and helped to inform a lot of the contents that are specific to Nigeria within this talk. Head and neck cancers, the peak incidence in Nigeria is between the 3rd and 6th decades, and the male to female ratio ranges from 1:1 to 2.3 to 1. And most are
Dr. Step, please,
yes.
Can you change this slide? We can see only one slide since the presentation. If you can, okay, like that.
It's better like this?
Yeah.
Okay, is that better now?
Yes, it's better.
Yeah.
Okay. So unfortunately, what's common from what I've read in Nigeria is a late presentation of disease. People present with advanced stage disease, and unfortunately in that situation, the only treatment options are palliative with surgery or chemotherapy and radiation therapy as available. And there are few, if any, reports on the outcomes of head and neck cancers in Nigeria. So as I mentioned today, I'm trying to highlight the most common cancers in Nigeria. And so I'll go through these one by one. It's a bit of a whirlwind, so hopefully it's not too much information to take in all at once. Starting with oral cavity cancer, you see here, this is a classic example of a lateral tongue squamous cell carcinoma. So it has this exophytic nature, and that's also a very common location, and I'll come back to that point in a moment. As I mentioned earlier, the anatomy of the head and neck is quite complex, so it's in close proximity to very important structures. This shows the front part of the mouth, and then this is a cross-section looking down on the mouth, so looking down on the tongue and the mandibular teeth, and then you see also the larynx down below there. And then this is looking up to the roof of the mouth, and then the uvula in the back. And then just a closer up picture of the tongue. So the most common subsites of cancers in the oral cavity are in the buccal, the cheek surface, the palate, what's called the retromolar trigone, which is right behind the last molar, alveolar ridge, which is your upper and lower gums, the oral tongue, the floor of mouth, and the mucosal part of your lip. The risk factors for oral cavity cancer are really broad, so the residents hate it when I ask them this question. But basically, the predominant risk factors are tobacco consumption in the form of smoking or chewing tobacco, as well as something called reverse smoking. And this is kind of a winning combination if you want to produce a cancer with alcohol consumption, and I'll come back to that in a moment. In addition, such things as betel nut and kola nut, Plummer-Vinson syndrome, and then this poor dentition and chronic irritation combined with the entire next column is really a situation where chronic inflammation allows for constant cellular turnover and the opportunity each time the cells turn over to produce a cancer. So as I mentioned, this is a very common location for oral cavity cancer. So the floor of mouth, the lateral part of the tongue, the gingival buccal sulcus, so the area between the cheek and the gums. These areas make up about 75% of oral cavity cancers, and that's because of that relationship of tobacco and alcohol consumption. So the consumption of alcohol basically breaks down the mucosal barrier of the mouth, and then that allows the carcinogens of the tobacco and the smoke to seep in and allow to produce a cancer. So people with oral cavity cancer tend to present with difficulty or painful swallowing, pain in the ears, bleeding from the mouth, trismus or difficulty opening your mouth, bad breath, taste disturbance, or a sore throat or mouth greater than 3 weeks. The prognostic factors for oral cavity cancer include the size of the tumor. So obviously the larger the tumor, the worse it is. The depth, the thicker it is, the worse it is. If there are already lymph nodes present, the type of cancer, the histology, whether or not there's spread beyond lymph nodes called extracapsular extension, and then the subtype of squamous cell carcinoma. This here is the staging system for oral cavity cancer. It's kind of beyond the scope of today's talk to go into this in detail, but it's just here for your reference. And this is the overall staging system. So the mainstay of treatment for oral cavity cancers is surgery, and this is usually followed immediately with reconstructive surgery, again, because of the imperative need for function of the oral cavity. If the cancers are later stage, so at T3 or T4, this is followed by radiation plus or minus chemotherapy. Chemotherapy alone or clinical trials are reserved for patients who are in a palliative setting, so a non-curable cancer. So getting back to our same guy with the same tongue cancer here, this would classically be reconstructed with soft tissue. So we try to replace like with like. And the soft tissue of the oral cavity is actually nicely replicated by the skin and soft tissue of the forearm. So this is what's called a radial forearm free flap. And so basically it's a transplant within your own body. So we take skin and soft tissue from the forearm along with an artery and vein from the arm. And then we implant those into an artery and vein in the neck to produce this reconstruction here. It's not the same tumor, obviously, this is a different patient, but this, you can see how it nicely replicates the anatomy that's already there, and people's function is quite good after this surgery. And then you contrast this with a mandibular cancer. So this is a cancer that invades the side of the mandible there and then onto the tongue. Again, we try to replace like with like. So we replace the bone of the mandible with most often the fibula bone from the leg. So this is, sorry for the gory picture, but this is a real life example. This is the top part of the mandible up high here. And then the defect or the cancer has required removal of almost all of the mandible on that side. And the best way to reconstruct that is with bone, and particular fibular bone. So the fibula is a non-weight bearing bone, so it's kind of an extra bone, we'll call it. And we can remove that with the overlying skin paddle along with the artery and vein. We're able to what's called osteotomize the bone, so cut the bone into pieces such that we can fit it onto a reconstructive plate to reconstruct that curvature of the mandible. And as you can see, although the surgery itself looks quite gory, the cosmetic result following the surgery is actually quite good. So I'm going to move on now to oropharynx cancer. So that's cancers in the back of the oral cavity, and these are most commonly, you see here, a cancer of the tonsil and the base of tongue. If I was giving this talk to a group of people from Europe or North America or even South America, the number one thing that we would be talking about today is HPV infection as the primary risk factor or the primary etiologic agent. But I'll come back to that in just a moment as to why that's not the case in Nigeria so far. So this again goes through the complex anatomy of the oropharynx. You see the bottom of the tongue here closely intersects with the swallowing function. And then here you see it a little bit more close up, the back of the tongue and the tonsil area. And so there are 5 different subsites of the oropharynx. There's the soft palate, the posterior pharyngeal wall, the lateral pharyngeal walls, the base of tongue, and then the tonsil. So once again, as I said, HPV is really the driving risk factor for oropharynx cancer in the Western world. It seems as though in Nigeria, it's still that combination of tobacco and alcohol consumption, in addition to things like dietary restrictions, cola and betel nut chewing, syphilis, occupational exposures, previous radiation, and immunosuppression. How do people present with oropharynx cancer? Usually, once again, with difficulty or painful swallowing, pain in the ear, a mass in the neck. So greater than 30% of patients present with a neck mass, which is metastatic disease to the neck, coughing up or spitting up blood, and what's called globus sensation, or the feeling like something's stuck in your throat. So this is the diagram of the HPV virus here, and the virus is, like I said, the most common risk factor for head and neck cancers in the oropharynx in North America, but it does seem as though there's not nearly as many oropharyngeal cancers caused by HPV in Nigeria. This is a study that my colleagues and I did in Canada, where we demonstrated an increased rate of oropharynx cancer across Canada of about 1.5% per year in men, slightly less in women, and that trend has continued beyond these years. So HPV-related oropharynx cancer is actually considered an epidemic in the Western world. So you see the end of this graph goes up to 2007, and in blue you have the oropharynx cancer, and in red you have cervical cancer. So you see oropharynx cancer has now far surpassed the incidence of cervical cancer. So it seems as though it's still the case in Nigeria, where it's older men that are heavy tobacco and alcohol users that tend to present with oropharynx cancers. They present at late stage disease with a poor prognosis. And then you contrast this with HPV positive patients. I have a woman shown here just because there's more women than there were in the past that have HPV related cancers, but there's still more men than women. Overall. They tend to be younger with no tobacco or alcohol consumption history or very little, and they have much, much higher cure rates. So in the range of about 90% cure rates. The differences are so stark between HPV positive oropharynx cancer and HPV negative that we actually now have two different staging systems. So there's an HPV positive staging system, and that's contrasted with an HPV negative staging system. The standard of care for treatment does depend slightly on if you live in Canada or the United States, but I would still say that the standard of care remains radiation therapy plus or minus chemotherapy. Myself and my colleagues across the country have done several large institutional studies to try to compare the outcomes of what's called robotic surgery to replace radiation therapy and chemotherapy. So this is a picture of the Da Vinci robot that we use here. And you can see the surgeon is sitting over in a console in the corner of the room. And then you have a second surgeon at the head of the bed. And the surgeon sitting at the console manages these long, very flexible arms to allow you to perform surgery in the back of the mouth without making any incisions on the face. This surgeon that sits by the head of the bed manages the important other structures close by, like the eyes, the teeth, the lips, so that you don't cause any injury to those structures during the procedure. So I'll move on now to nasopharynx cancers. These are cancers at the back of the nose. This shows a cancer at the back of the nose here. Just to orient you, this is the back of the right side of the nose. So you have the nasal septum over on your right-hand side of the screen, and then the eustachian tube opening on the left-hand side of the screen. So once again, I kind of circle back to the important anatomy of the structures in the area. So you see the back of the nose. This is where the cancers arise back here. And this just shows a closer up view. The sphenoid sinus is right kind of behind the nasopharyngeal area, and you see the close proximity to the internal carotid artery and then several very important cranial nerves. In terms of risk factors for nasopharynx cancer, there are intrinsic or genetic factors and then extrinsic or environmental factors. So nasopharynx cancer is common in Inuit populations, Chinese populations, and in Northern Africa. So this might explain why there's a higher rate of nasopharynx cancer in the northern parts of Nigeria and less so in the southern parts. It seems to be a winning combination of the genetics of those different populations with EBV or Epstein-Barr virus infection that produces the cancer in most situations. Other environmental risk factors are nitrosamines, which you find in salted fish, and chemical fumes, as well as wood dust. So I mentioned that EBV is one of the most common viral causes of nasopharynx cancer. This is just a picture of the virus. It's also known as human herpes virus, and it's a double-stranded DNA virus. So in terms of how people present with nasopharynx cancer, you see they present most commonly at the bottom of the graph there with a lump in the neck, or basically metastatic disease to a lymph node in the neck, followed by blood in the saliva, hearing loss because their ear has now filled up with fluid, epistaxis or nosebleeds, nasal obstruction, tinnitus or ringing in the ears, and then the cranial nerve palsies. So weakness in those nerves because of the close proximity to the nerves. This is the staging system for nasopharynx cancer. And because of the close proximity to the carotid artery and those cranial nerves, we prefer radiation and chemotherapy over surgery for nasopharynx cancers. And we heavily use chemotherapy more than our other types of head and neck cancers in this situation. So we use it either before and in addition to the radiation therapy, and then even sometimes after the radiation therapy. So what do we do if there is recurrent or persistent disease? Re-irradiation is a possibility, but is fraught with many complications like soft tissue breakdown and erosion of the base of the skull. We can use what's called brachytherapy, or basically seeds, radiation seeds, to manage the recurrence, or we can proceed with surgical excision and radical neck dissection. I'll warn you, the next picture is a little bit gory, so hopefully nobody's eating their lunch or their supper. The surgical approach is shown here. So you see the incision below the eye and then around the nose. That actually heals quite nicely. But you see in the top corner here, what we have to do is take the maxillary sinus and completely move it out of the way. It's called a maxillary swing procedure, and that's to gain access to the back of the nose. This was first described by a physician with the last name of Wei in 1991. You can see why we reserve this as kind of a last resort. Sinonasal malignancies. So even though this is only about 1 centimeter anterior or in front of the nasopharynx, they have a completely different profile, completely different risk factors, and different treatment and prognosis. So this is the picture of a cancer in the nose. This is the nasal septum here, and this is one of the turbinates here. You see here, these are cross sections through the sinuses. So maybe, I'm not sure how many people already know this, but this is the frontal sinus up top here, the ethmoid sinus in the middle, the maxillary sinus below it, and then the sphenoid sinus in behind. So in terms of which locations are most, which locations are the most common, the maxillary sinus is the most common location there, followed by the ethmoid sinus, and then the frontal or sphenoid sinus is quite rare. There are many different causes for sinonasal cancers, but squamous cell carcinoma remains the most common. Unfortunately, almost all people that have sinonasal cancers, not just in Nigeria, but everywhere in the world, present late. So they present with kind of vague symptoms that many people could have without having a cancer. So they present with such symptoms as some pain in the mouth. Later on, they can present with a mass in the mouth, nasal obstruction, or a little bit of bleeding from the nose, some changes around the eyes, like some tearing of the eyes, and then facial or cheek swelling, as well as I mentioned, some hearing loss. Nodal metastatic disease, so people who present with a lymph node that's positive in the neck, is extremely rare, but it's also a very poor prognostic sign. So essentially, if they already have metastatic disease, it's very challenging, if not impossible, to cure this disease. This is the staging system for sinonasal cancers, and it's divided up by the different sinuses here. So in contrast to the nasopharynx, the mainstay of treatment for sinonasal cancers is surgery, unless it's contraindicated. So unless there's involvement of the brain, the carotid arteries, or what's called the pterygoid muscles or bones. Postoperative radiation therapy is very common because of the fact that people present late, plus or minus chemotherapy. And chemo and radiation alone is reserved for inoperable or metastatic disease. So this is the kind of incision that we would use to gain access to the sinuses. And again, a bit of a disclaimer, the next picture is a little bit gory, but as you can tell here, the close proximity to the eye sometimes necessitates us removing the eye. And of course, this is not a great cosmetic situation for this person to go out and resume their normal life. So we don't always use what's called free flaps or tissue reconstruction within the body. Sometimes we use prostheses. So this is actually a prosthetic eye.
And as you can see, especially if you put on a pair of glasses, that's actually a very nice cosmetic result. People wouldn't necessarily notice that there was something wrong there. So the last cancer that I'll talk about today is what's called larynx cancer, or cancer of the vocal cord. You see here on your left side, there's a large kind of exophytic looking mass lesion on the vocal cord itself. And this is what the vocal cords would look like ordinarily, so if there weren't that mass there. And the laryngeal anatomy is further divided for the purposes of staging cancers into the supraglottis, or the area above the vocal cord itself, or the glottis, and then the subglottis, or the region below the vocal cord. And so the larynx cancers are also divided into these three groups because they have very different behaviors. Supraglottic larynx, or the area above the vocal cords, tends to have its own unique pattern for spread around the area above the vocal cord. They tend to present more commonly with advanced stage disease, and with lymph nodes it's been spread to the lymph nodes on both sides of the neck is quite common. And then when you contrast this with glottic larynx, or vocal cord, lesions that arise just on the vocal cord itself, they actually behave quite differently. So they're usually quite a bit less aggressive, their staging is different, and their treatment is different. Something to talk about is that I find larynx cancer or glottic cancer patients present either early or late. So they either come in to the hospital reporting that they have some changes to their voice, and they come in nice and early and they have a small lesion which is easy to treat, or they ignore it and then carry on with their smoking and alcohol consumption, and then they present in a situation like this. So this is a CT scan showing erosion of the cartilage in front of the larynx here, and also severe compromise of the airway. And so people present essentially in extremis in airway obstruction, and they need to be managed urgently. In terms of the risk factors for larynx cancer, I'm not really trying to be funny, but kind of here, really it's smoking followed by alcohol consumption. And there is some reports that reflux or heartburn, again, this acid coming up from the stomach and constantly washing over the vocal cords can cause some chronic irritation and potentially a cancer. This is the staging systems here. So treatment, as I mentioned, varies very much by site and stage. So early stage cancers are usually treated with radiation therapy, but occasionally we use laser surgery. And later stage disease is treated with a larger surgery followed by radiation plus or minus chemotherapy. So this is an example of laser surgery. So you see the tumor in the right side of the vocal cord up above there. And then you see it below after it's been removed with laser. And you see just below the vocal cords there is what's called a laser safe tube and a neuropathy or something to protect that tube so that we don't start a fire in the airway. This is another example of a glottic cancer here. And you see how nicely they can heal after laser surgery. So it is quite helpful in certain cancers. Total laryngectomy, or removing the entire voice box, is certainly something that we do more commonly, though, because people tend to present later. Although the surgery isn't necessarily larger than the other surgeries that we perform, it's more complex in terms of the patient's outcome or their ability to function after the surgery. So we pay close attention to their initial medical condition. They have to have good support systems in place because people often become quite depressed after a laryngectomy. And we as surgeons and physicians heavily rely on our allied healthcare professionals to help us with these patients. So nutritionists, speech and language pathologists, physiotherapists, and nurses. So when we remove the larynx in total, this is it cut in half, and you see what's called the epiglottis up top here, and this is the tumor over the glottis here and the upper part of the trachea. And you can see on each side are the lymph nodes in the neck that we remove at the same time. The cosmetic result isn't terrible. This usually heals up quite nicely, and they have a permanent stoma in the front of the neck there for which they breathe. So you might have noticed up until now, I haven't talked much about the workup of these cancers, what we do when we think someone might have this cancer, or the follow-up. It's because It's actually quite similar amongst all of the cancers that I've talked about today, so I thought I would review that at the end because it applies to all of the cancers. So as with anything else in medicine, the most important thing is a good history and physical examination. And if you're concerned about a lesion in the upper aerodigestive tract, we then proceed with endoscopy, or what's called flexible nasolaryngoscopy. If this is not available to you, people use an indirect mirror examination. Most of the time we can perform a biopsy just in the clinic, but occasionally we need to take people to the operating room to perform a biopsy. We request HPV and EBV testing as applicable, so it depends on where the lesion is located. We then need to perform staging, so either in the form of a CT scan or an MRI. And then distant staging, so the chest or the lungs are the most common route for spread beyond the head and neck area. And so we usually proceed with a CT scan of the neck before pursuing treatment. For any patient where we're considering radiation therapy, which as you've seen is most patients, we request a dental evaluation prior to treatment, and sometimes also a Panorex is required, or an X-ray. We heavily, as I said, with larynx cancer, but with all cancers, we heavily rely on our nutritionists and our speech and language pathologists to help us care for these patients. Sometimes, as I mentioned, we have to examine people under anesthetic, depending on the location of the tumor. Often we need pre-anesthetic studies, particularly before those larger operations that I discussed. So things like ECGs and blood work. And with every single upper aerodigestive tract cancers that we treat, we review that case ahead of time in what's called our multidisciplinary tumor board. So once weekly, we meet together as a group, other surgeons like myself, radiation oncologists, pathologists, radiologists, you get the idea. Everyone meets together and reviews each case to decide in a consensus fashion on what the best treatment would be for that particular patient. The follow-up, as I said, is pretty homogeneous across all of the cancers that I've discussed, with the exception of nasopharynx cancer. So all other cancers we follow for up to 5 years, and we progressively follow them less frequently with time. Nasopharynx cancer, because late-stage disease is more common, we follow them for 10 years. And in terms of imaging after treatment, we perform a CT scan about 3 months after the completion of their treatment. And we don't perform any further imaging unless they have new signs or symptoms that we're concerned about. Many of our patients get radiation treatments. So we perform a thyroid stimulating hormone check of the blood work about every 6 to 12 months to make sure that they don't have hypothyroidism. We heavily rely on our speech and language pathologists even after the patient's treatment. And of course, smoking and alcohol consumption are usually the reason that patients arrive on our doorstep. And so we would be amiss to not provide counseling to patients that are amenable to that, to try to prevent either this cancer from coming back or for them to develop a new cancer. And as I mentioned, we're also heavily reliant on our dental colleagues. So in summary, head and neck cancers comprise a diverse group of malignancies. They're particularly complex due to the proximity of important structures and intricate anatomy. The most common risk factors for all of the cancers I talked about today are smoking and alcohol consumption. And as with all cancers, prevention is the best, I guess, so-called treatment. And I'm certainly happy to answer any questions that you might have.
Thank you.
Oh, thank you, Dr. Stephanie.
Thank you.
Yeah, hold on. Oh, thanks. We're going to be right back.
The Edo Professionals in Diaspora is coming back with their 4th show on Apple TV this weekend. Date 20th February 2021 at 7 p.m. Nigerian time and 1 p.m. Canadian time to present Head and Neck Cancer. The program is featuring a Canadian healthcare professional, Dr. Stephanie Obaseki. The show will highlight the prevalence area of head and neck cancer in Nigeria, the risk factors of head and neck cancer, the signs and symptoms, the diagnosis, and treatment. Furthermore, Dr. Obaseki has additional consultation service for Edo State. Join us this weekend on Nebo TV.
Oh, welcome back. Thank you, Dr. Stephanie, for that wonderful presentation. It's very detailed, and I have my question here. I wrote some questions when you were presenting. I hope, Dr. Bano. Hello, Dr. Bano.
I think he's out.
Is there? I think it's on
oh,
mute.
Okay. Yeah, sorry, sir. Yeah. Hello, Dr. Bano. Go ahead, sir.
Yeah. I think this is what I call a top of the line presentation, and I think as we move in this series, we're beginning to show how sophisticated we are, bringing this information to the people of Edo State and then the healthcare professionals in Edo State. My first question to our presenting doctor today. First, I want to thank you for taking the time, being a wife, being a mother, becoming a physician, and taking your routine work, and to also take this time to devote to Edo State. I am very, very grateful.
Thank you.
Network problem.
But I am extremely grateful. So my first question to you is that the young generation are beginning to be involved in oral sex and all kind of different things. And HPV, as you mentioned in some of the cancer, how does that relate to this younger generation that is more into oral sex and so on and so forth?
Right.
Yeah, so that's the most common reason that people would have HPV in the oropharynx. And so what we know is that people who HPV is in the Western world is ubiquitous, meaning most people at some point in their life would have HPV in their upper airodigestive tract. But there are specific things like earlier age at we call sexual debut, or increased number of sexual partners, particularly oral sex partners, does increase your risk of not being able to clear the HPV virus after infection. And so it is a concern if the behaviors are changing in Nigeria, that this situation whereby the HPV-related cancers are not very common, that could change with time.
Yeah, I have one quick question there. Is it a transmittable disease, HPV?
HPV is a sexually transmitted disease. That's right. Yeah.
Oh, okay. So it can progress to cancer.
Right. So as I said, you get HPV initially as an infection, and most people clear the virus. So they clear the infection on their own. There is a subgroup of people that don't clear the virus, and we don't know why that is just yet. But in those people, if they keep the virus around for greater than 10 years, then they are at risk for producing a cancer as a result.
Wow.
Dr. Basaki, can we talk about the HPV vaccine?
Go ahead.
Because I know in Canada there's a HPV vaccine for male and female of younger age.
Yes.
Do you want to elaborate on that?
I would love to. Thank you. This is an area of interest for me.
Okay.
So up until now, the HPV vaccine I can only comment on Canada because I don't know the availability elsewhere in the world. But in Canada, it's been available to young girls in the school system roughly around grade 8. And it's free of charge within the school system in Canada, in most provinces. And the reason to provide the vaccine to these young women was in an effort to prevent cervical cancer. But as you saw on the slide that I presented earlier, it's well known, at least within the medical community, that cervical cancer is actually taking a back seat to oropharynx cancer. And oropharynx cancer is much more common still in men. And then it's also more common just overall. And so there's been a bit of a lag in the policy development around providing the HPV vaccine to boys. Initially, it was provided to boys
to establish herd immunity, which I think, unfortunately, because of coronavirus, everybody is familiar with that term now. The initial goal for giving boys the vaccine was to provide herd immunity for the girls. But as you can see, it's very important that we provide vaccination to young boys to prevent oropharynx cancer. This is slowly changing, but kind of frustratingly slowly changing. This is a well-known phenomenon, and we've only just started vaccinating boys with the goal of preventing cancers for them.
As we are speaking, and try to pull out the full definition of this HPV, the full definition, so that people will know what we are talking about. Yeah, I'm going to post it right now.
Okay.
Okay. Is this the definition?
Yes, human papilloma virus.
Virus. Yeah.
And there are 100 subtypes at least of human papilloma virus. There are only a few of those subtypes. So this is a virus that also causes warts and other, benign diseases, but some of the subtypes are cancer causing.
Okay. So, Dr. Bano, is there any other question? I have.
Yeah. There's a question. She mentioned bitter nuts, which is not available in Nigeria. You tend to find bitter nuts and the leaves in Asia country. But kola nut, she mentioned, in our part of Edo State, kola nut is very prevalently used. Can you just give a little comment on kola nut and how it relates to the etiology of these cancers?
Right. Okay. So I've actually never tried kola nut, so I can't talk too much about the product, the nut itself. But my understanding is that people chew it for their, I guess, pleasure. And the issue, although betel nut is not available in Nigeria, the issue is similar to kola nut in that it causes quite a bit of inflammation, particularly in the inner part of the cheek. And that chronic inflammation from the chewing causes breakdown of the mucosal barrier and allows some of the carcinogen in the nut to absorb through the mucosal barrier and potentially cause a cancer.
Dr. Dorothy, do you have anything to add to that?
I just wanted to add, in terms of the smoking, if you want to please elaborate on chewing tobacco, the snuff, because a lot of older folks back home usually prefer the snuff. Snuff is like a tobacco leaf mixed with all kinds of chemicals that they put in the back of their cheek, and they put it on all day long. If you want to elaborate on how this can increase their risk of oral cancer.
Great, thank you. So a little bit of a similar idea to kola nut and betel nut, chewing tobacco, but I guess worse in a sense because the tobacco itself is a more potent carcinogen. But chewing tobacco with any other products causes, once again, some irritation and breakdown of the mucosal barrier in the mouth and in the throat. And so that breakdown of the mucosal barrier allows the cancer-causing agents within the tobacco to seep in through the mucosa and produce a cancer. Also, just that chronic inflammation that it causes inside the mouth causes a chronic or constant cellular turnover. And as I mentioned earlier, the more times the cells are reproducing themselves in a setting of inflammation, the more it's going to be a possibility for the cells to, when they're dividing, make a mistake and produce a cell that could cause a cancer. So it's less common for chewing tobacco or snuff to cause larynx cancer, which is caused by smoking because the smoke is constantly going over the vocal cords, but it's certainly extremely common to cause other cancers like in the oral cavity, oropharynx, and then the upper part of the esophagus.
So I have one question I wrote. I think you have answered pretty much almost everything, but except for this nasopharynx cancer that is prevalent in the northern region of Canada and China. So can you explain to us why it's common in these areas?
So I guess nobody knows for sure, but the theory of us all, like Pangaea, or all of the continents once being one, means that the genetics across all the northern parts of the world have some relationship to one another. And so that is the commonly held belief as to why the northern part of Canada, northern Alaska, basically northern Africa, which is quite a bit lower, but that's why we think that people in the northern areas tend to have a higher prevalence of nasopharynx cancer.
Mm.
And then China is yet another population of people that is at high risk.
Mm. Mm. Is it something a correlation with the weather or something? Because
yeah, it's a good
China,
question.
they said the weather in China, because of the pollution, maybe it's a kind of a factor for this cancer.
It's a really good question. I don't know the answer. People always cite pollution, as a risk factor, but to my knowledge, it hasn't been rigorously studied in the setting of nasopharynx cancer. So it's certainly a possibility, but not that I'm aware of. Do we know that?
Okay. Okay, thank you. So
Thank you.
yeah, Mrs. Obaseki, Madam.
There is no
question at all.
Do you have any questions on your side today? Because I don't see any. Oh, there is just one from Yogi. He said, how can we share more awareness for people in Nigeria for early symptoms of?
I don't know that I'm the right person to answer that question.
Dr. Obano maybe can help.
The way to share this information is what we are doing right now. And for the person who asked that question to make sure that people log in every 2 weeks to watch our program and get more information on this type of issue. The reason why we brought this head and neck cancer into being is that sometimes you see these lesions in people. They tell you they just had they just rubbed some bisugu or bitter leaf on the lesion and it will go away. Or they will choose some kind of stick and then these lesions go away. These lesions don't go away. It has to be done surgically. And I have seen lesions like this in Nigeria where some primary care physicians say, so amoxicillin, flagyl, and all those things will take them away. The answer is it will not take them away. It requires surgery, it requires radiation, and it requires trained people like Dr. Stephanie Obaseki to look at this patient and evaluate them.
Right. And if I just want to add, because as Dr. Obaseki mentioned, most of this cancer are discovered at a late stage, advanced stage. And when it's discovered at an advanced stage, the prognosis is very, very poor at that stage. So early detection and prevention is the key. So if you notice anything, any changes in your mouth, your neck, any lump, you need to seek help. You need to go see your doctor right away so that they can do some assessment and see if anything is wrong or any indication to refer you to specialists.
May I also add, as a dentist, we often see these early signs of cancer in the mouth. And that's why we recommend that patients visit their dentist at least once a year, because then it's picked up. There are also certain things to look out for. For example, Dr. Stephanie touched on them, but I just want to kind of tell you again. But if you see any white spots or patches in your mouth that haven't healed for about 3 weeks, any ulcers in the mouth that haven't healed for about 3 weeks, any red patches or swellings that haven't healed again for 3 weeks, if you notice any voice changes or any bumps in the skin that have just been there for 3 weeks, because usually the body can fight these infections, it's worth going to see your dentist, because as they say, prevention is better than cure. And as Dr. Stephanie said, the earlier these things are detected, the more treatable they are. So I can just emphasize the importance of, looking after your oral health and also visiting your dentist as well, because it's what we're trained to do as part of the checkup. We're not just looking at the teeth, and we're not just counting the teeth. We're looking at the mouth, also the glands as well for any swellings. It's part of the routine. It's just screening.
Yeah, I couldn't agree more. And we work really closely with our dental colleagues here, not just for patients who have known cancers, but for precancerous lesions. We're constantly in communication with our dental colleagues here. We find it quite unfortunate that dental examinations are not covered across Canada with our public healthcare system. I have a question for this group. Where you are dental evaluations covered with the public healthcare system, like particularly in Nigeria, or is it something that people have to pay for personally?
People have to pay for it. People have to pay for it.
And Dr. Alma, is it the
well,
same?
There's a system in Central Hospital where they have a place where you pay minimum amount and then get evaluated. I have visited that area and tried to make some improvement at one time. But they have what I call, I'm trying to use a very correct word here, dentist who practically would prefer to remove your tooth than to really make an adequate examination. Except you are well connected. And if you're not well connected, you really don't get adequate evaluation. But I hope this group, with time, will be able to impact on some of these issues. And as we work with the state governor, who is also Obaseki, to make a lot of changes during this short period of time that he is in the office.
Okay, thank you, Dr. Bano.
Thank you.
Any other question from the comment section?
No,
No
they're
question.
just accolades and quite informative and stuff like that.
Yeah, I saw some of the
Yeah.
comments here. I can put them out here. Very informative.
Beautiful presentation. Beautiful presentation.
Yeah.
Thank you, and thanks for having me.
Yeah, you're welcome.
And I also I want to kind of put this information out here. The CEO of the group is not going to be happy with me, but I am going to put it out that eventually we have a consultation through this committee group to do consultation on subspecialty in Edo State. Hopefully, eventually we can work with the governor to provide a place for us. And to those of you who are watching this program, if you know of Mrs. Igbinoba, please tell her we are trying to reach her so that we can start planning on a consultation for our people. The governor cannot be the only one doing everything. He cannot be the dentist. He cannot be the lawyer. He cannot be the bricklayer. We all belong to that state. The state belongs to Dr. Stephanie and her husband, and to our young dentist, to Inekme, to Dr. Ayela. So we all must pitch in, just like these people are pitching in. If you find your street is filled with grass, organize the young people to clean it up. You don't have to throw dirt everywhere. So let's move our state forward.
Thank you. Thank you, Dr.
Thank
Obano.
you.
I wanted to discuss about that, and I think you have said it all, that we are also planning a consultation for Edo citizens, especially training the healthcare professionals so that they will be independent in the state. So before we end today's program, and we have one other presentation about corruption in the system. I think one of the government personnel was given money to renovate a clinic, and he embezzled the money. The clinic was not well renovated. I'm going to pull out the video. Meanwhile, if there is any question with regards to the presentation of Dr. Stephanie, please just go ahead and ask your question before we proceed to the next discussion.
Okay, there's a question here from Trinity. He said, in terms of the diagnostic techniques, what is the most effective way of diagnosing this infection?
For HPV?
She didn't specify.
I think she means HPV.
Probably.
So there's two different situations. There's the infection itself, which is usually long since the patient is no longer infectious at the time of them producing the cancer. So I don't know that it's feasible to measure HPV infection in real time, nor necessary, because there's a very small proportion of people who get the infection that go on to produce the cancer. But in terms of diagnosing tumors that are HPV positive, there are multiple different ways of doing that, usually within the biopsy specimen itself. I can go into detail with that, but usually we send our pathology specimens off and they measure HPV using PCR testing.
Okay. So yeah, I have one last question. I have one last question for Dr. Obaseki before she will leave. I think you are planning a consultation for Edo State. Can you please explain to us more clearly what type of consultation you are planning for the state?
I guess that's still very much in the works. You know, I would be happy to review with physicians in Nigeria after we organize, you know, some kind of process for this. You know, if they have a concern about a particular lesion, what course of action they should take in terms of investigating the lesion and or treatment.
Okay, thank you. Yeah, we're going to be working with you before then. We're going to be working with you. Thank you, Dr. Stephanie. Thanks.
Thank you, and thanks again for having me.
Yeah. You're very welcome.
So if you want, you can leave. Otherwise, you can stay while we proceed to the next presentation. This one is about Edo State. We're going to be presenting about a politician or a government worker who embezzled the money that was given to him to renovate a clinic in Edo State. So, okay, yeah. So I'm going to play the video right now.
Doors. Please, can you take it up? Take it up. You can see this is the level of job. This is the renovation of over 8 million naira that was done by Comrade Destiny and Abulele and the contractor. You can see man's inhumanity to man. Come this way. You can see man's wickedness to man. This is supposed to be a project that has been done. This is the toilet. There is no doors. They fixed only tiles. As you can see, no painting. The windows are still there. And I wonder how people can inhabit. Look at they only change the tiles. Come over to this other room. This is another room. This is what they call renovation. They fix only tiles too. Look at the roofs. Look at the roofs. I have a video. Look at the roofs. This where that Destiny can take treatment here. I wonder. For patients to come here and take treatment, I'm even wondering how can somebody lie down to take treatment. Look at it. And this is what we call renovation. Millions of taxpayers' money has been expended on this project that has been siphoned by the chairman and the contractor handling this project.
Take it to where they get water from.
Look at where they look at their well. This is a well.
Madam, please come and take us to the backyard.
This is a well. This is supposed to be an health center. An health center that is not even healthy for people to live in, not to talk of bringing sick patients to. This is supposed to be an health center that is supposedly renovated by Comrade Destiny and Abulele-led administration. This is an health center. You can see the level of renovation that has been done. You can see the level of renovation. Indeed, this is the Oga Kwata Kwata of all renovation. This renovation is the Oga Kwata Kwata of them all. You can see, look at the net. And they claim this building has been renovated. Just tiles they fixed for a whooping sum of over 8 million naira. Only tiles that was fixed in this project that they have used as a conduit pipe to siphon taxpayers' money from Ovia. Look at a project that was embarked by a failed administration. Having served for 3 years, there is nothing visible to show this, but they will tell us that they have renovated. It's on the book. We challenge them to come and refute it. It's on the books that that this project was awarded, money has been paid. This is the level of work that was being done. The feast only ties, as you can see. It is only ties that was feast. So you can see the level of wickedness, the level of man's inhumanity to man. As we are live at Maza. Is this bone? This is Maza World. This is Oropharynx. You can see the signboard here. We came on for an on the spot assessment of all these things because most of these chairmen, they are leaving office. They are writing different memo now, claiming that they have done so many projects. But as you can see, this is one of the projects that they claim they have done. So this is a project now. They will write that they have done Oropharynx Health Center. But look at what they have done. It's a show of shame. The owners, take it to them and take it to him. Okay, if rain they fall, they will go to one room.
Yeah, so one room.
Okay.
You see?
And they did not come to work, okay?
At all.
Did not. No, the contractor. Because this project.
No, the contractor does not come.
But the feast ties now. Only the ties.
It's always ties, the feast.
And look at it, because this project is supposed to be full renovation.
Okay.
Now, that's why we are here.
Okay.
Now we are seeing that they did only ties.
Only ties.
And there is nothing that has been done.
Nothing. The whole thing, they leak.
As we speak now. So how do you manage in this health center?
It's just we get good nurses.
Okay.
If not, they will have gone since.
Yeah. Can you imagine? And they come to work.
Yes.
Even in this condition, they still come. I'm surprised seeing this woman yourself. That even in this condition, you can even stay. Because
Monday to Monday, they stay.
Even staying here itself is not healthy.
Okay.
Don't talk of bringing a sick patient
to
this kind of building.
Okay.
It is a show of shame. It is something that the whole world will see. The whole world, we will bring the world here. We will bring the world to come and see this. The governor will come here by himself to come and check this project.
When the chairman will come here,
he
will say, hey, what is the name of this man? Have you seen what the contractor has done? We will go and arrest this contractor.
Yes.
And it's lie. He will devise. They ate the money.
Can you imagine? Can you imagine?
You see?
Sir, what's your name, sir?
Thank
you very much, sir. Okay, you are the owner of this, the owner of the village.
I'm one of the elders.
Thank you very much, sir.
Yes, sir.
Thank you. We will make sure that this matter. You see this health center, the chairman, the contractor. We will make sure that even if the chairman leaves office, they will come. He will come here and do this project.
Okay.
They will not go scot-free with this project because this is wickedness of the highest order.
Okay.
How can you, as a chairman, this is your community. Even if you don't use here. You may have a relative. What if your brother's child, your mother's child, your aunties, your cousins get married from here, and maybe the person happens to give birth and the child is sick? Is this the place that they will rush the person to?
All.
So it is very, very unfortunate that we have this kind of people leading us, and that's why we as civil society activists, as opinion molders and opinion builders, we are going around. You understand? We must help government because the governor is very, very serious.
Yes.
That this chairman, he wants their account of stewardship. What have you done for the last 3 years? So much have been expended. Now look at one of the fraudulent project that was done. With over 8 million that was used in awarding this project, the feast only ties. Roof was not. The whole roof is. Look at the windows. Look, no net.
No net, nothing.
The windows were nothing was done. In fact, they will say nothing was done in this project.
Even this net that here,
the contractor must be arrested.
Buy the net to.
Okay, it's even the nurse.
Yes.
That fits the net. It's all right.
Thank you.
Thank you very much, sir.
Okay.
Thank you very much, sir. Madam. Please, how many of you are here?
There's 2 in Oba and 2 health attendants and 2 security.
Okay, 2 health attendants, 2 security. So how do you cope during the rains, madam?
If rain is falling, we have to put some place that can leak, we put buckets. So like here is leaking. All here, all the rooms are leaking except this one. Okay. This one that is not leaking, but it's dusty. Even the bath that was here, it was me that educated the bath and the help of the youth that helped me to. No, my hair.
Bath.
My hair.
Okay, bath.
Yes.
Okay.
It was the youth that helped me to eradicate the bats. If not, we won't have that time because the smell of the physics, because of the smell.
Okay, Ma, we thank God that we've been able to come here. We've seen here. We know what you are passing through. Because for me, I cannot even stay here. So it is courage for you guys to be here. Because me, I don't see here as healthy for living. Not to talk of bringing somebody who is sick to this kind of place to take treatment. It is the highest form of wickedness. It is man's inhumanity to man. And we will not let this injustice go unpunished. So we sympathize with you. We are in collaboration with you. We are in solidarity with you. We will join you to make sure that whoever has stolen this money, both the contractor, both the local government, we will bring them to book. This project will be done. It will be completed, and we will also come back to commission this project.
Thank you.
So I appreciate you. What's your name, ma'am?
My name is Mrs. Sandra Iwarikoko.
Okay. Thank you very much. I'm Comrade Bali Joseph. No problem. I appreciate it. Thanks.
Thank you.
So that is it. That is it. We have been seeing a lot of this type of corruption in the system. So this is not the first one. And Dr. Obano, what is
I think he's not here right now.
I think he left.
I want to ask you, when was this thing happen? I mean, when did it happen? This you just show. When did it happen? Is it in this state? Is it in this present government or
no? We don't. I'm not sure. I'm not sure when.
Oh no! Before we show things like this,
we have to verify.
We have to verify. We shouldn't be showing things blank statements because people we can be taken to court for this.
Yes.
Because we are presenting something we are not sure. So before I personally, before I show anything like this, I want to know where it is coming from, when it happened, who was involved, and all of that. It's very important. It's very, very important.
Local government chairman, Honorable Emmanuel.
Yeah, you said Obobaifo of via local government, yes. And then the local government, whatever. But when is very important. Because if it was during like a long time ago, 20 years ago, and then you're showing it now, the present government can take offense.
It's not going to be happy,
No. So we have to be very sure of what we present here.
According to what the guy said, the president's government asked him to go do inspection. Okay, so this man went there under the order of the state government, this present administration. So we don't know when the money was allocated to Honorable Emmanuel to renovate the clinic. However, this clinic is being regulated right now by the current government. So that is what I can say about this video so far. Dr. Obano, go ahead.
I saw this video and I sent it to Nekme to look at. What if you listen to the beginning of this video, is the governor that sent all these young men to go from local government to local government, checking out all these chairmen, what they have done. And then this man now reported this issue on the video. So I saw it on the internet and I played it and I called Nekme and I says, something needs to be done about this thing. And actually, it's sickening to see something like this. I don't think this is from the old or 20 years ago. I think this is very recent. Not only very recent, and the reason that I decided to bring this thing up today is that you see somebody from Canada who is not even from Edo State taking time to present a lecture, taking time to contribute her time to the state. Then somebody who is born in that land, who is supposed to be watching over people, is doing a clinic like that where your own chicken cannot even stay.
Right.
own goods cannot even go inside. So that's the correlation between this presentation and this clinic. I am going to say to you that this person will be held accountable.
Definitely. I agree with that. If the person is still alive and well, they should hold them accountable. This is not fair at all.
Yes.
You can't just collect 8 million and then do nothing. Just retire.
Yes. And I think those of us who live abroad, we need to begin to hold people accountable. And this is one person that needs to be held accountable for his action.
You know, it's the type of system that they are running in Nigeria. He's not the first person. We have seen a lot of corruption in the system over these years. So, yeah.
Yeah, but it's like when we were doing Edo Institute, we shipped a whole bunch of medicines and everything to Edo State. And I remember somebody who worked in custom that we went to go meet, who didn't want to be involved in it. But this person, in the later part of his life, ended up at UBTH. They were looking for medicine to heal his foot. They could not, so they amputated his leg. 2 days after his amputation, he died. So if he has helped us then to collect medicine, if he has helped us then to collect all the equipment we shipped to Edo State, he probably would have been alive today because those equipment would have been used for him.
You see?
So that's the point I'm trying to make here. The chairman who is talking and saying this, it can be his dad who can be coming to that clinic tomorrow. It can be his son. It can be his brother. It can be his sister. But you cannot continue to eat your cake and have it. So this committee is going to be looking into this case. And we are going to take action.
So how are we going to do that, sir?
Well,
we are looking for reliable, if I can help Dr. Obano, we are looking for reliable and dependable, accountable people that will help us take care of what we plan
there
to
is
do.
EFCC, there is
I
a
know a
lawsuit.
lady, Mrs. Aigiamu, so she's absolutely accountable for everything you put in her hands to do.
Yes, there's EFCC, there's lawyers in Nigeria. We can get a lawyer to sue this person, person.
Oh, yeah.
So these politicians are very powerful in Nigeria.
Yeah, they're very corrupt.
They are very powerful.
If they are powerful in Nigeria, they are not powerful here. He can be sued here.
They are not
We can sue him from here. We can sue him in the court here.
Oh, okay. But he's not living here.
Even if he doesn't, but he cannot come here.
He cannot visit here. He cannot send his kids to come and enjoy.
He cannot send his children here.
Yes.
Exactly. Yes, that's what we do. Kenua can tell you. Kenua sued the head of state. Kenua Obasaki, he sued the head of state. He took Abdul Salam to court. And they settled out of court. Just him alone. He didn't call anybody. He didn't say anything. He took him to court.
So if this, if it is the governor that approved the assessment of this video, so obviously they're gonna give him an update.
Exactly.
So he's gonna take it
follow up. We're gonna follow up with the update.
So we have
this is a case we're not just gonna let go. We're gonna follow up with the updates. And then if nothing is done, we're gonna sue the contractor and the person itself. We will sue them here, we'll sue them back home.
So I guess the first step now will be, how do we bring it to the attention of the governor that we are paying special interest to this case?
Exactly.
To see how
tomorrow there's a meeting tomorrow that somebody will see this video. Yeah.
Okay.
I think this is an interesting video. Now that you said you know enough about it, like it is a recent thing, not like age-old.
The man said that the governor Obaseki ordered the inspection of the clinic. So
no, he said Obaseki, the governor ordered the inspection. But he didn't say when the work was supposed to have been done. That's what I was interested in. Like, is it recent? But Dr. Oban already explained that it's a recent thing, not.
He didn't indicate the time.
No, that's what I was saying, because he did not indicate that. That's why I was concerned that, you know. But Dr. Obano, like I said, already explained that to us, and I quite understand. And
this is one of those cases in Nigeria of embezzlement going on in the system, in the political.
This is just one of a million. Yes. Because they do that all the time.
Yes.
Erosion. Patrick Equals was making noise all over the place, calling me. I said, listen, why are you calling me? Did I do any contract on erosion and I didn't do it? He said, oh, no, I just want to tell you I'm going to protest. I said, you don't need my permission. Go and protest. I'm not the contractor. And I don't know the contractor. Then he called an innocent guy in Texas who is not even the person, just because the person is answering the same name. He called the person and he almost got sued for it. So one has to be careful.
Mm-hmm.
Later, I had to tell him, I said, you were focusing on the wrong person. It's not that guy that did it. It's another guy. And I directed, and I told him who the person was. That the person is right there with you in Benin, not in the diaspora.
I think we are going to do more investigation on this clinic.
Yes.
We
should do a lot of investigation.
We are going to write our own complaint and our own report and file our own complaint against whoever is involved.
Yeah. Where is Obob Bifo of Ovia? Where in what's the biggest village close to that?
We'll research.
I was trying to search now. But anyway, we can do that later.
You can see why mortality is very high in Nigeria.
Right. And the life expectancy is like very, very low.
Exactly, because of things like this. How can you put your own family member in
if
such
somebody is sick and goes to the clinic like that, the person is as good as dead.
The risk of even getting more infectious disease is even higher than what you're looking for.
Look at the well.
The woman
these days, everybody does borehole. You put a well in there.
No.
The nurse said the toilet was smelling. So she asked.
Was there even a good toilet there? The well is that bad.
Oh my God.
Yeah.
And the roof is all leaking, everything.
I know. Looking at comparing it to what I'm used to, it's just so scary that how people can go in there for any services.
Exactly. So we in this committee, we are not the police people, but as everybody contribute their own quota, we will continue to speak out against issues like this.
Yes. So more awareness to it.
Look for people who do something wrong, but something like this cannot be accepted.
Cannot be accepted.
It's not acceptable.
Under the carpet for no reason. No.
For those of us who have been following the trend of corruption in Nigeria, one of the major ways that these people are embezzling our money in Nigeria is through this idea of contracts. When they award contracts to a senator,
they don't even start sometimes.
A senator, a member of House of Rep, these are the people taking the contracts. So at the end of the day, they will end up not completing the work, and they will embezzle our money. When you look at cases of corruption in Nigeria, it's through contracts. We have been following the trend. I know what is corruption, the way they practice it. They don't just go to the treasury or Nigerian treasury and take money, or a Edo State treasury. No.
We know now, yes.
They take contracts. Contracts are awarded to these politicians. They don't allow people who are.
They don't even have to be politicians. Some of them are not. No. Don't generalize like that. A lot of people we know, some of us know, are not politicians. They take the contract, they don't do it, and they share the money. They use the money for their personal needs.
I will tell you today, if a contract is awarded to someone who is not a politician, I guarantee you that contract was awarded to a politician or a connection from a politician.
Right.
Given to somebody. I'm not a politician.
No. I know so many that are not connected to any politician, and they don't do it. And you can't do them anything.
The conflict of interest. I think so many things are happening here. The lack of accountability.
Yes.
Knowing that you can get away with it,
because they've been getting away with it.
Yes. And also here they use contract, but the way they do it is a little bit different. That a lot of people bid for it. People bring their proposal, and you have to seek out experts in whatever contract you want to give. Not just any blowjob can award that contract to, right? And if they did not follow through, there's severe consequences, and the government follows. But back home, that is not the case.
I'm telling you now that most of the contracts are awarded to the politicians. Look at NDDC. If you follow the trend of NDDC, what happened?
We've all been following that.
What happened during the hearing when the people who are supposed to investigate the case were saying that Akpabio, stop, don't talk, because Akpabio was trying to reveal their secrets.
Right.
You see,
so it's part of the corruption.
Yes,
from the beginning to the end.
That they have been operating in Nigeria. This one is just nothing compared to others. We are talking about billions.
We are talking about
Edo State.
Edo State.
I know. I'm just saying
whether it's small, stealing starts from 1 penny.
Yeah.
You can steal 1 kobo, you eventually steal 10 kobos, and then it goes on and on.
Yeah.
We are talking about our state, how we can move it forward and better. I think that's what we are on about. Yeah.
Right.
So
I think this is a starting point for me. It's good to fix this, Whether he's a politician or not, he's just a human being like any of us.
He's a citizen.
He's a citizen. He shouldn't do it. I don't believe in that because they are politicians, so we can't find out the truth. No, that's not.
This one is about local government chairman. The contract was awarded to a local government chairman. So he gave
and then the local government chairman did not perform.
Yes,
he did not.
He just pocketed the money and that was it.
Renovated. They said he only.
And this is if he's a local government chairperson, it means he lives in that area too, right?
Right.
He might not be there. You don't. They don't live in their local government like that.
They don't. They live in it. They live in
the city. Yeah, but he's from there. He must have families there now.
Abuja. It's in Abuja. Most of them, majority of these politicians, they will sit down there in Abuja, where the money allocated for all these contracts and everything, they use it to live.
That's not fair at all. That's not fair.
In Abuja, why people will be suffering, dying in poverty. No.
That's not fair.
About this, though.
And the other thing is they give them hardship allowance.
Yes.
That hardship allowance is the one to go use to see their consistency. Like, come on.
Yeah. When you investigate this case now, you realize
you don't have a conscience at all.
This chairman is not even in Benin, in Abuja, sitting there in Abuja.
Wherever he is,
You have to.
No, it's not fair. Fair is fair. It's not right. Right is right.
Anyway, I have to go.
Okay.
Yeah. Me too.
So thank you guys for the visit.
Thank you for a great show.
Thank you.
Bye, everyone. Have a great
great weekend and a great week ahead.
Tomorrow,
yeah. Yeah,
tomorrow.
2 p.m. I think.
Okay, then. Tomorrow,
yeah. Bye. Thank you.
Must move forward. Move forward. Backward never. Yo.
Edo Professionals in Diaspora program is a team of skilled and experienced Edo professionals in diaspora who are willing to use their professional skills to support and effect change in Edo State. The program is designed to give opportunities to Edo professionals in diaspora who are concerned about the plight of the people to voluntarily use the skills, wealth of knowledge and experiences to provide support to individuals, families, groups, and communities in Edo State. In the same vein, Edo citizens in diaspora can equally benefit from the program. Their primary goal is focused on providing online and physical support to Edo citizens, such as healthcare services, donations, online programs, professional trainings in engineering, finance, social services, physical support, training and donation of computers, and more. Let's join the state government to move Edo State forward. The program is scheduled to commence in January 2021 in collaboration with Nebo TV Canada and Edo Diaspora Women for Governor Gordon Obaseki. The program is organized by Dr. Nosahai Obano, Mrs. Ukineb Obaseki, Mrs. Adesuwa Obasoha, founder Edo Diaspora Women, Mr. Felix Odigye, Nekme Obasoge, and Austin Osawaru. Come, join us in this quest to move Edo State forward.
Edo must move forward. Move forward.